Yeah.
I did.
Why don't I take an opportunity to introduce Arne, who's our keynote speaker today. Arne Owens is the former Deputy Assistant and Secretary for Planning and Evaluation for the U.S. Department of Health and Human Services. So welcome. Arne, I'm going to hand the baton to you. If you can take us forward, that would be superb.
Sure, will do. Well, thank you very much, Dan. Yeah, I lost, well, we've just been through it, so I don't need to review that. But back on the line now, so good. But thanks, Dan. It's a pleasure to be with all of you today and to be able to discuss the HHS response to the COVID-19 pandemic, provide some of the details on that. You had a brief intro of my background there. I should point out I am no longer at the Department of Health and Human Services. We all left in January. And what I'm about to provide is not the official information or an official statement of HHS, but it is based on a retrospective look that my office took of the pandemic response prior to our departure in January. So hopefully it'll be informative. My position, or in my position, I was not at the center of the pandemic response. My office was in a supporting role. We did primarily policy review, looks at every action, pretty much every action HHS or its various agencies were planning to take prior to their launch. So we did get a good perspective on what was going on. And again, my comments today are going to be based on that more recent retrospective look that we took at the pandemic response. As I go through this, just think about information systems challenges that we encountered and relate them to the various justice systems and the systems that you all are dealing with on a regular basis. I think there will be some hopefully you can draw some good insight from what we've just been through and actually continue to go through now. But I do want to provide an overview of the pandemic response, beginning from the very beginning on January 27th, 2020, when our Secretary of Health and Human Services, Alex Azar, declared a nationwide public health emergency. Shortly thereafter, the World Health Organization declared a public health emergency of international concern on January 30th. At that time, 114 countries were reporting 118,000 COVID-19 cases and nearly 4,300 deaths. In the US, we had just over 1,000 cases that had been diagnosed. 29 people had died. Of course, a lot has happened since then. In December, or as of December 16th of last year, the CDC was reporting over 16,000 cases and 306,000 deaths. And of course, now we know that it's gone much higher. So that was really the beginning. The HHS COVID response initiative was really defined by the investments that were necessary to meet the needs of 4 sequential and overlapping phases of the pandemic. And I'll go through those briefly because I think they're informative to the strategy we followed. They included containment at the front end, which was basically tracking the dissemination of the virus within a community, and then using isolation or quarantines to keep those infected from spreading the virus. Now you can just imagine the data requirements here. They're absolutely critical. And we'll talk more about that. The next phase was mitigation, or the actions that people and communities can take to slow the spread of a new virus with a pandemic potential before the therapeutics or vaccines are available. We're talking there about things like wearing a mask, social distancing, washing your hands, There were also in many states lockdowns, closing of certain businesses and that sort of thing. All that was mitigation related. And then we launched into a third phase. We call that absorption. And that's really the phase where the response to a surge in cases is met as rapidly as possible and as effectively as possible. Now you can just imagine the data requirements here as well. Where's the surge occurring? And I'm sure you all followed news media reporting on that over the last several months. The last phase, of course, is eradication, or control of the infection to the point at which transmission will cease within certain specified areas. Data information is critical here as well, and we'll talk more about that. So to meet the goals of each of these strategies, and remember these phases are overlapping. There's no firm line when you go from one to the other, but I do think they outline kind of the approach that we took. To meet the goals of the strategy, HHS made investments into 4 key areas, and I just want to chat about those as well. We needed to address the shortage of rapid diagnostics and lab testing. We needed to address resupplying the strategic national stockpile. We needed to address the creation of a data analytics platform, which we'll talk about more. We call it HHS Protect. And then finally, the development of therapeutics and vaccines, which we were able to accomplish through Operation Warp Speed, which, in my opinion, I think in the opinion of most folks, was quite successful in the development of a vaccine and the initial distribution out to the states. So the report we did really focuses on pandemics, specifically the COVID pandemic. Pandemics are generally a very complicated problem. There are many challenges that require persistence and rapid adaptation. HHS, along with our federal and private partners, responded to all of this, starting with containment and mitigation of the virus, and eventually reaching a point where the problems were quickly addressed and vaccines were developed that could accelerate herd immunity. With any response, of course, and I'm an old Army guy, retired Army guy, and we always talked about needing eyes and ears on the ground. You need a view of the battlefield, so to speak. In this case, we needed a view of the healthcare landscape, and we needed an understanding of what was going on. So again, you can see how, as we move forward through this, how important having accurate data and information really is. By the end of 2020, HHS was in fact absorbing the various surges around the country in various locations and meeting the challenges. Quite frankly, I think it's quite an achievement that we were able to accomplish all of this. We produced a roadmap for government leaders and other stakeholders to use in future public health emergencies that will only be built upon and added to by the new administration. And I think it's going to benefit everyone down the road. But let me talk now in a little more detail about the response. As we all recall, the COVID virus reached the United States from China, where it was actually developed, or actually broke out in the fall of 2019. That, of course, led the WHO to declare the world is facing a pandemic. In the U.S., of course, we immediately convened a White House task force to work to contain the virus, initially by restricting travel into the U.S., mobilizing medical countermeasures, preparing communication strategies to inform the public. The medical, public health, biomedical community worked to better understand the virus, understand its spread, how to provide appropriate health care. The initial focus, of course, as we recall those 4 phases, was containment. The U.S. first initiated this strategy to prevent the coronavirus from spreading to communities beyond the known outbreaks. From January to March, travel in the U.S. was restricted, flights were suspended, travelers were prevented from entering the U.S. The CDC and U.S. Customs and Border Protection began enhanced health screenings to detect ill travelers on either direct or connecting flights in from Wuhan, China. The objectives were to reduce the importation of COVID-19 cases into the U.S. from areas with sustained widespread transmission. Quarantining was enforced for those who had been exposed on cruise ships and repatriated Americans from highly infected areas. Early in the pandemic, before data reporting was required of all facilities, state reporting showed that COVID-19 was disproportionately affecting people who reside or work in long-term care facilities. On February 28th of 2020, a case of COVID-19 was identified in a woman resident of a long-term care skilled nursing facility in King County, Washington. Investigation identified 129 cases of COVID-19 associated with that facility, including 81 residents, 34 staff members, and 14 visitors. 23 persons died. That sort of kicked things off, as you'll recall. And then we had the similar problems arise around the country, especially nursing homes in New York, which we all recall, New York and New Jersey. To prepare for the unexpected need for post-acute care from COVID hospitalizations, several states, including New York, required nursing homes to accept COVID patients for a post-hospitalization stay, which led to even more deaths. Again, we're developing, during this time, we're developing an understanding of the disease and how it spreads and how to react to it and how to respond so that it doesn't overwhelm the healthcare system. So, states, leaders are making the best decisions that they can based on the information they have at hand. Then, of course, the focus began to shift to mitigation. As the number of cases and deaths grew, hospitals and nursing homes were being overwhelmed by infected patients. Early efforts by the federal government resulted in decreases in certain targeted hotspots like California and New York City. But despite the success in those areas, the virus spread quickly to other states, spread across the country, and the incidence of virus increased again. So we turned to this mitigation strategy. According to the CDC's community mitigation framework, the goal of mitigation in areas of local COVID-19 transmission is to slow its spread and to protect all individuals, especially those at increased risk for severe illness, while minimizing the negative impacts of these strategies. Community mitigation efforts are intended to reduce and prevent local transmission through hand washing, social distancing, mask wearing, staying at home when sick, things like that. We're all familiar with that by now. Community mitigation strategies seek to ensure mainly that local healthcare system capacity will not be exceeded, and also to be able to protect vulnerable populations. Hospital capacity, treatment capacity is a big concern, has been a big concern throughout all of this. You recall some of the news media reporting on the shortages, but projected shortages of ICU beds. Use of data and modeling was vital in making these projections and developing or enabling the development of an understanding of what was going to be required. Now, remember the initial response to the COVID virus outbreak was primarily focused on local areas, on emergency rooms, on hospitals, on EMTs, local health departments. So big concern there with their capacity being overwhelmed. The virus continued to spread. The federal government's response was defined largely by three of the four primary investments that I've mentioned at the front end. rapid diagnosis, that's testing, a resupply of the Strategic National Stockpile, and the creation of HHS Protect to collect the data on treatments and health outcomes. So you can see the importance of data. We needed to have a clear view of the battlefield, a clear view of the treatment landscape. Rapid diagnosis and lab testing. Let me talk a little bit about that. It was a challenge from the outset. The first test kits were developed and distributed to state and local public health laboratories on February 6th. HHS expanded COVID testing capacity by establishing a government-wide working group. We worked with the NIH, and the NIH launched their Rapid Acceleration of Diagnostics program. They called it RADIX. You know, we love acronyms in the federal government. To speed innovation in the development, commercialization, and implementation of technologies for COVID-19 testing. There were really four initiatives as a part of all that. One, to fund point-of-care home-based tests, as well as improvements in clinical laboratory tests. Another was to develop community-engaged projects to assess and expand testing for underserved and vulnerable populations. Next was to support non-traditional approaches to address gaps in testing. And finally, a focus on scaling up existing or late-stage testing platforms to increase testing capacity. And rather than attempting to construct a wholly new public testing infrastructure, HHS adapted the existing infrastructure as needed, investing over $1 billion through the Defense Production Act to expand testing capacity in the United States. And in addition to that, we worked with the state governments in setting goals and federally allocating nasal swab and scarce testing supplies and that sort of thing. In March, the CDC began updated their guidance on COVID testing and other prevention strategies as the understanding of the virus develops. Starting in March of 2020, FDA began encouraging third parties to develop diagnostics. FDA issued several new guidance documents to encourage the development of tests. Now, it's important to just point out, when these changes in guidelines, when these new guidelines were developed, they needed to be communicated, and they needed to be communicated to industry, to health departments across the country, and to the general public. And so a variety of tactics and methods were used to do that. The bottom line is, by the end of June, the FDA had issued emergency use authorizations, we call them EUAs, for 150 different tests. So that was critical to the entire mitigation effort. Resupplying the Strategic National Stockpile was another focus in mitigation. We're talking about ventilators, personal protective equipment, or PPE. You probably heard that acronym thrown around. By that, we're talking about masks, gloves, gowns, that sort of thing. The supply level of the Strategic National Stockpile, quite frankly, at the front end, could not meet the demand created by the pandemic. The U.S. addressed the problem through a worldwide coordinated effort to move the supply chain and distribution process forward. Production in the U.S. was accelerated by invoking the Defense Production Act to support American businesses to produce what we required. Ford, General Motors, General Electric, they all jumped on board and converted their production lines to make ventilators, for instance. Project Airbridge was created to shorten the amount of time that it takes for U.S. medical supply distributors to bring personal protective equipment and other critical medical supplies into the U.S. A lot of people don't realize that much of this equipment, this PPE, is actually produced overseas. So we had to get it produced, had to get it transported and distributed around the country. But this was a successful operation. Just to give you an example, over a couple hundred different flights into the U.S. Were organized by FEMA, and as of June 18th, I think, of last year, and there's been more since then, approximately 249 flights had been scheduled by Operation or Project Airbridge, bringing in much needed medical supplies. Imagine for a second the coordination requirement there. Identifying the manufacturers overseas, coordinating the air transport into this country, getting the supplies then distributed out to healthcare providers around the country. It was really a public-private public-private partnership that was leveraged in all of this, accelerating the production and supply of this much-needed PPE. The Defense Production Act was used at least 106 times to strengthen the U.S. industrial base and increase our manufacturing of critical equipment here in the U.S. As of December 20th, the Strategic National Stockpile contained 9 times the number of N95 masks in the inventory than when the pandemic began, along with more testing supplies, more diagnostic tools, etc. States, hospitals, nursing homes, the bottom line is they're better prepared now to meet local and statewide health challenges related to COVID-19. And we've seen that is in fact the case, because we've seen a decline in overall requests for medical supplies. But next, you'll recall I mentioned the need for data. So probably of most interest to everyone on this call today is what we dubbed HHS Protect. At the outset of the pandemic, and this is kind of interesting, HHS did not have a modern, scalable, centralized data infrastructure that could rapidly secure, integrate, and disseminate the sort of granular information that we needed. So HHS leadership at that time was often forced to operate on inconsistent and incomplete data. Now, the CDC did in fact have a system, the National Health Safety Network. It's an important surveillance system. It focused on fighting antibiotic resistance, and there were other mechanisms in place. But this system did not result or did not enable the sort of detailed, nationwide, very granular view we needed of what was going on out there across the country. So while many HHS agencies had access to these partial views of information, we just did not have access to the comprehensive view of all the pertinent information in near real time to make data-backed COVID response decision. This is not a new problem. I'll just throw this out. We've been fighting the opioid epidemic for many years. One of the key measures of the problem is drug abuse deaths, for instance, overdose deaths. Drug overdoses are reported up through the chain to offices of chief medical examiners in states across the country, but not every state reports their data to the CDC. The CDC has a Center for Health Statistics that gathers this information to put together a report for us every month at HHS, and we can see where the problem of drug overdose deaths is most severe across the country. At least we think we can, except not every state reports. During most of my time at HHS, for instance, California was not reporting that data. That's a state of 37 million people, so we really didn't have the sort of near real-time reporting that we needed to enable an understanding of where there were certain surges in opioid abuse. Another problem is that is gathering information from emergency rooms across the country. There was what we call the drug abuse warning network in place several years ago, but until recently, their funding was cut, so it didn't exist anymore. The great thing about that drug abuse warning network, we called it DAWN, is that emergency rooms would report whenever there would be an admission for any drug overdose into an ER. And so we'd have visibility on where potential surges were taking place, where there was a specific problem, and the federal government could roll in behind states and offer assistance. So again, having visibility of a problem is not something that's new. And in fact, today's unprecedented pandemic and potentially future pandemics demands near real-time data sharing across government, across diverse sectors, with the public. So HHS went to work on this and developed through a collaborative effort, HHS Protect. We did this through the Office of the Chief Information Officer at HHS in coordination with the CDC, with the local, state, and tribal governments, with the Office of the Assistant Secretary for Health at HHS, the Assistant Secretary for Preparedness and Response, and also in coordination with the White House U.S. Digital Service. Data continues to be a driving force in the department's ability to respond to the health emergency. To execute an effective, coordinated whole-of-government response, HHS, through HHS Protect and its platform, we call it the HHS Protect platform, it requires health-related information. We call it a health-related outbreak and crisis management response. We expect to have, as a result of all of this, and have it now, a common operational picture of the current state of the world as it relates to COVID-19, including how the virus is tracking, current testing capacity, trends and results of the testing, shortages, identifying shortages in the supply chain, in care capacity, and now increasingly that we're tracking the vaccination success, the delivery of vaccines, the actual administration of vaccines, all that's being tracked very closely. So as a result of the HHS Protect platform, the department was able to integrate, manage, analyze data from the wide array of information that's out there. That capability now enables key stakeholders from across HHS and its operating divisions, which include CDC, other federal government partners, FEMA, OMB, others, along with state governments, to have the data, what we would call the accessible, consumable, up-to-date, accurate, and complete data pertaining to the outbreak, and then enable informed, effective response decisions. It's absolutely critical. Now, I'm not an expert in all of this, so I'm not going to go into all of the minute details around HHS Protect, but suffice it to say that this data, it's extremely complex. It's the result of a substantial effort by hospitals, by states, by federal personnel who collaborate and meet daily. This information is reported from hospitals up through HHS Protect, and we now, in fact, have a much better vision of what's going on out there, and that enables much more effective decision making. That's mitigation. Then, of course, we moved on into absorbing the surge of the pandemic. Remember, these phases are overlapping. The hard work done to meet the challenges during mitigation gradually transformed into a more coordinated, quick, and effective response. A range of actions taken from June 2020 to the present addressed more immediately and effectively surges in patient hospitalizations, challenges in nursing homes, scarcity of personal protective equipment and medical equipment, and timing and location of diagnostic testing. You all have, I'm sure, been tracking the news media reporting over the last many months, and you saw last fall into early winter the surges out in California. You've seen that. You've seen surges in other parts of the country. HHS Protect gave us the real-time data that we needed to really see what was going on and to be able to respond to that. Now, one major shortcoming in the ability to respond, as I mentioned, was the lack of near real-time data from hospitals on confirmed cases and admissions. As I discussed earlier, to achieve the vision that we really needed, we got HHS Protect up and running in April of 2020. By July, it was receiving a widespread use. It was fully implemented in July of 2020. The percentage of hospitals treating COVID patients who were reporting at least once a week through HHS Protect increased from 80% to 99% as of November 20th. The percentage of hospitals reporting every day increased to 96%. Improvements of data reporting also enabled a more rapid response with the provision of capacity expanding resources. Mortality rates for hospitals with COVID-19 dropped as a result of all of that over 80% since April of last year. Data and information was also critical to the safeguarding of nursing homes. By mid-December of 2020, approximately 42% of COVID deaths had been among residents in nursing homes. Since June of 2020, federal and state governments had increased access to PPE and testing, provided guidance and education to staff of nursing homes, and provided the resources on infection control and monitoring, the testing staff, as well as residents for illnesses, and provided nursing homes with rapid point-of-care diagnostic testing devices, which were helpful in getting that problem under control. CMS was all the Centers for Medicare and Medicaid Services. We call it CMS. They were also involved in this by some focused action they took related to nursing homes. In October, well, I'll skip over that. But in addition to focusing on nursing homes, improving testing for COVID-19 was another big challenge. It was a challenge from the outset. As I'd mentioned previously, first test kits were distributed in local public health laboratories in February 6th. We got some of those initial kits, and that's just expanded since then, since that time. Rather than attempting to construct a wholly new public testing infrastructure, HHS did adapt the existing infrastructure as needed. As mentioned before, investing substantially in the resources that were necessary to get all of that up to speed. Since March of last year, CDC has regularly updated their guidance on testing and other prevention strategies as the understanding of the virus continued to develop. And you've all seen and heard evidence of that through media reporting. on the wearing of masks and that sort of thing, and the need to socially distance and take those various preventive measures. Again, you can really understand, or you can really see the requirement for information systems, for data reporting, and helping with decision making and the allocation of resources. But you also see the importance of getting information out to the public so they have an understanding of what actions they can take. I talked about the availability of personal protective equipment. I won't go into any more detail on that, but it was a big problem at the outset. The follow-on concern was in certain areas, certain regions of the country were experiencing some of the shortages. Once we got the Strategic National Stockpile up and running and shipped out, much of that problem disappeared. And now HHS is able to respond to requests that come in from the states and from healthcare providers. Again, because we can receive the requests, but we can also see where the surges are, and we can anticipate requirements. I think a lot more easily than we could at the front end. Reinforcing COVID hotspots with additional medical personnel. Again, these are some of the resources that can be provided to designated hotspots where we're really seeing a surge. HHS responds to requests for support from states and localities. We began doing that as far back as January of last year. The actual personnel that we can deploy include practitioners and staff from the U.S. Public Health Service, Commission Corps. A lot of people we don't realize we have those resources available. You may have seen them on television. They wear Navy-like uniform, but they're actually commissioned officers in the U.S. Public Health Service. We also have a national disaster medical system and disaster medical assistance teams that we can deploy across the country. And that was done earlier on and continues to this day for that matter. You'll recall from early on in the pandemic, the Department of Defense deployed Navy hospital ships, field hospitals, medical augmentation teams to hotspots. Again, all of this is based on projections of the scale of the problem and the difficulty in providing much needed medical care based on the healthcare capacity that's available in a certain area. Again, back to the requirement for data. We have to have a picture of what's going on at a granular level in localities, in hospitals, so that the projections can be made, so that decisions can be made, and resources can then be properly allocated. Whether it's, again, sending PPE out to certain regions, whether it's sending healthcare personnel out to reinforce certain regions, data is absolutely an essential requirement. Today, federal medical personnel continue to be deployed to hotspots. I don't have the data within the last couple of months, but back in December, as of December 9th, there were 2,608 medical personnel deployed for the COVID-19 response. These are federal medical personnel, Public Health Service, or National Guard personnel. In total, 23,000 or just under 23,000 U.S. government personnel were deployed for the whole of government response. Finally, the last phase, the fourth phase, which we dubbed eradication. You're not going to eradicate this unless you build herd immunity within your population, and the best way to do that is to develop a vaccine. And so HHS developed Operation Warp Speed. Now the name's been changed, or at least it's been announced by the new administration that they plan to change that name but that was the name we came up with because the focus was on getting a vaccine developed as quickly as possible. In March, hospitals, especially those in areas with high rates of COVID, struggled to treat COVID patients. So Operation Warp Speed was formed. It was a partnership between HHS and the Department of Defense. It was launched back in April, and a lot of effort was placed in developing a vaccine. You've all been through this. You've heard the media reporting on it. The first to develop and actually get FDA emergency use authorization was Pfizer Pharmaceuticals, and then Moderna developed their vaccine. AstraZeneca has one over in the UK. Johnson & Johnson's Janssen Pharmaceuticals has one that's in the hopper right now. The goal was to get these vaccines developed. They were developed in record time. I don't think it's ever been done that quickly. But then the follow-on goal was to get 20 million distributed throughout the country by the end of December. I think it took like a week in January to hit that goal, but it was in fact hit. And then, of course, once the vaccines are distributed, the challenge becomes getting them actually administered, getting shots in arms. And so that's been the focus over the last couple of months, and that continues. I've been out of action here for almost a month, so I don't have the most current, up-to-date information on that. I can tell you that there have been challenges at the state and local level. Most people don't realize the federal government doesn't deliver direct healthcare services except through the VA, the Department of Defense, and the Indian Health Service. Everything else is done through the states, and so the states develop their plans. As of 1 November, I think every state had their vaccine administration plan into the CDC, and the states have then been executing their plan over the last couple of months. Some states have done well, others have not done so well. I attribute that largely to the planning that was done and the strategy that they chose. But it is getting better. I mean, even here in Virginia right now, it's getting a lot better. One big challenge has been the supply, because the demand is huge. There is still a limited supply, but the new administration has signed various contracts to even boost the number of vaccines that the last administration ordered up. So it'll all come about quickly. I do want to talk about, just briefly, some lessons learned. Public communications is absolutely essential. The need to do what I would call strategic communications planning, and here we're talking about public communications, public relations, that sort of thing, to inform the public. Absolutely critical. And this is my own personal opinion. I don't know that we did enough of that at the front end that enabled an effective communication with the public. The information certainly got out there, but quite frankly, I think a better plan would have been helpful. You need a second area that we need is we need a detailed pandemic response plan. I think going forward, you're going to see that, but prior to this current response, a lot of focus has been on bioterrorism, and not necessarily a focus specifically on a worldwide pandemic. It's totally unexpected. And so the planning, the detailed planning that was needed at the front end wasn't necessarily there. So we had to build it. And I think we built it effectively in just a matter of days, weeks. We put the plan together at HHS in coordination with the White House and FEMA and other agencies. And we started to get it all under control through the various phases that I just described. I would also say that partnerships are very important. I mentioned the public-private partnerships that were critical at the front end, the collaborations with the private sector, Ford, General Motors producing ventilators. We saw a lot of that. It's absolutely critical. We need to practice and rehearse the federal response to pandemics. We also need to look at what we'd call risk communication, a risk communication plan to ensure that the public is able to understand how to keep themselves and their families safe. This kind of goes back to the need for some strategic communications planning, but it also requires us to look at how the public responds and what their compliance may be with the recommendations that come out of the federal government. As we've seen reported, and as you've seen just walking around your local supermarket or your local shopping mall, not everybody complies with the recommendations, be it wearing a face mask or socially distancing, or that sort of thing. So probably more analysis needs to be done in that regard. And finally, we do think it's necessary to review the current authorities and regulations, especially the Pandemic and All Hazards Preparedness Act. That's something that Congress can get involved in and look at in the weeks, months, years ahead to determine how we can improve the response to public health emergencies such as COVID-19. So that's a kind of a summation of some of the details of our response. I tried to connect it to the need for data and information systems. Hopefully that was helpful. So I see Maria's picture on the screen, and that's my cue that my time is about to run out. But it's been a pleasure providing this information. I'm happy to take a few questions if you have some. And with that, I'll just stop talking.
Thank you, Arne. I appreciate it. And when I get back to discussing some housekeeping issues, I'll speak about the challenges we had here at the office. But I will tell you, Arne, that the wealth of information that you provided us in the time that I was able to listen, I'm so very grateful that we have this taped, and that not only we, the attendees, can review the messages, but that others that aren't registered will be able to see the value that you provide. The lessons learned was actually a question that I was going to ask you. Up until that point, I was looking at sort of summarizing your points to sort of review that you were discussing the challenges of the new virus and the vaccine issues, that you were talking about the inventory challenges that could have included the PPE and others. And then, of course, you were looking for the data availability, both retrospectively and prospectively. So I guess my question is this, that data focus, who would you think are the priority partners to bring to those tables? And I'm not referring to industry, because I know that we can help from a technical perspective. Mine is more, who would the practitioners be that should be represented? Of course, you touched on the White House, you touched on FEMA, of course, HHS. Are there other key players from a data availability perspective that we should consider?
Yeah, my personal view is we need a broad-based view of this across the federal government. Certainly HHS, certainly the White House, but any review of the data requirements, I'd have to say probably needs to involve all the cabinet departments, including DOJ, because DOJ has, Bureau of Prisons has a major issue with providing health care to residents of prisons and staff. But I would also say the Department of Housing and Urban Development requires, we need to have them at the table, because there are homeless populations out there that we need to think about and touch. The White House ought to be involved. Quite frankly, I think Congress is going to get involved in this and review all of this. What form that review will take beyond the GAO, I'm not certain just yet. but I'm sure they will get into it. One of the committees, or perhaps multiple committees in the Congress, will take a look at all of this. I do know GAO is going to get into it in some detail, and we'll get some detailed reporting out of that. But I think pretty much across government, everyone needs to be at the table. Department of Treasury was involved in this as well, because the provider relief fund dollars, that were appropriated, that went out to healthcare providers across the country. All of that was, it was appropriated by the Congress, right? But it was financed by the Department of Treasury. So I think pretty much everybody every federal entity ought to have some representation here. But I think the leadership probably falls back on HHS, to be the executive agent, if you will, for a comprehensive review, if not the White House, but that'll be up to the new administration.
Thank you. That's very valuable. We have seen from experience that some of the push for change as part of the pandemic impacts have increased the flexibility, the wherewithal, the attention to what are sometimes the improved processes or improved tools that stakeholders use. Do you see that same analogy for Operation Warp Speed as a game changer going forward? Obviously, the approval of the vaccine in such a quick time because of the criticality of it, we witnessed what was a warp speed of the approval. Do you see that as something that will be codified going forward or available going forward?
I don't know if it'll be codified. I would think that it would be available for use in an emergency. Drug approvals, vaccine approvals, that's a very deliberative process by the FDA. And the reason for that is to ensure the safety and the efficacy of the drug, because, ultimately we want to protect the public from a drug that might be harmful. So it's a very slow, deliberative process. This was an emergency process, and it occurred at warp speed. And the FDA, it was all hands on deck. They provided a focus on the specific applications for emergency use authorization, and they moved it out very quickly. One interesting point on Operation Warp Speed is the federal government assumed the financial risk to the pharmaceutical companies for the production, for the manufacture and production of a vaccine. The manufacturers actually started manufacturing the drug well before it was approved. Once they had a candidate that they thought would make it all the way through, they started producing it. So once that particular drug, the Pfizer drug, for instance, the Pfizer vaccine, for instance, once it received FDA emergency use authorization or approval, they had doses of that ready to go, and they started shipping. And we saw the reporting on UPS and FedEx getting them out across the country. So that's an interesting aspect of this as well.
Wonderful. I'm just going to bother you with two more questions given the limitation of time, Arne. The first one is NIMS and ICSC3 coordination and response an element that was utilized within the warp speed effort?
Repeat that for me again.
Surely. Is the NIMS effort and the ICSC3 coordination and response an element that was utilized in the warp speed effort? That comes from a gentleman by the name of Doug Oates. And Doug, I may recruit you on stage if we need clarification.
Yeah, you might need to do that. And that goes back to my initial cautionary note at the front end. I was not in the middle of the detailed planning and coordination around the pandemic response or in the development of Operation Warp Speed and how that would be implemented.
Well, we certainly understand that. And actually, of course, the NIMS itself and the references are about the incident command system. But knowing that you were on the perimeter of those sort of tactical issues, we'll defer, and then for the purposes of the audience, know that we will track down that response and share that with you. The last question that I'm going to refer to is, did you witness and do you think that it will resonate a cultural change within the federal government for bringing private sector partners to the table and thinking outside the box? I say that for to use the analogy of 9/11. When the world changed on 9/11, people would share information and they were bringing everyone to the table, and there was a little bit more leniency in not automatically saying we won't share, but what's your purpose in sharing? And as you made a reference to, bringing the right people to the table. Do you see that we're in that grace period or that honeymoon period right now?
Probably. Yeah, you have you have a sort of a competition between approaches. Is an approach going to be more government centric? Is it going to be more private sector focused? I think we demonstrated with Operation Warp Speed in particular, but also in the production of PPE and ventilators and that sort of thing, that we have to have the private sector involved. And we got more ventilators because big auto manufacturers converted their production facilities to producing ventilators. The federal government doesn't have that capability, so we have to have these partnerships. The federal government, the NIH is great, and they do vaccine research, but it's the big pharmaceutical companies, quite frankly, that carry the heavy load on that and do in fact the development of vaccines, and we've seen that. So there's got to be some close cooperation and partnership, and quite frankly, we need collaboration with the healthcare system. We're not like the United Kingdom. I mean, there is no national health service here. There are federal healthcare services that are provided on Department of Defense installations. We've got the VA, the Indian Health Service, we've got that, but the vast majority of the American healthcare system is all private sector. 80% of the hospitals are nonprofit hospitals. We also have for-profit hospitals, but we've got to have partnerships with the healthcare sector as well, and collaboration with them.
Thank you, Arne. We cannot thank you enough. I personally thank you for your patience in what were some of our hiccups. To bring the audience up to speed, our office internet connection was lost. The irony is that I was just about to tell everyone about some housekeeping issues that spoke to a potential storm that we will be experiencing later today and into tomorrow. So it doesn't bode well, but we forged through it, and we appreciate your patience in that. So I'll just return to some of our broader notes, and we will keep you in mind for the future, Arne, and thank you so much. We appreciate it.
Well, thank you very much. It was a pleasure.
Wonderful. So folks, I'm going to sort of return to some of my initial thoughts, only because according to my staff, I was talking to myself in the office. So that being said, imagine that the glitches that we went through this morning were somewhat like me tripping across the stage at the beginning of the symposium. We could use that as comic relief and hopefully get that out of the way so that the rest of the day and the session tomorrow continues without any sort of eventual concerns. With the limited time that we have before the end of this session, I just want to share with you that during this day and tomorrow, we are not only going to be providing you the valuable input as it relates to the pandemic response and to public safety reform, but we're also going to be providing you updates from each of our chairs, our committee chairs, and they will speak to the numerous accomplishments that they've made since what was our mid-year briefing in August of last year. That will include our law enforcement group, our CJIS group, our courts group, our corrections group, our tech and architecture group, and finally, as Dan mentioned, our most recent addition to the advisory committee team in the emergency communications and response group. Their accomplishments are significant. We have made reference to not only the partnership, the collaboration, But with the committees, I have to enumerate the fact that this is all volunteer work. So it goes beyond the relationship between member and organization to commitment to duty and commitment to service. So that is what you will see when we show you what our videos tomorrow morning that speak to some of those accomplishments. Also, we're going to be providing you some information on several of our programs, to include our cyber standards check program, which I noticed from one of the comments in the chat room, we should be concerned, or we should be more fastidious with the cybersecurity as demonstrated in our own breach. Rest assured, Bob, that I think that this was more of a storm issue than it was security, but you are absolutely so correct that so many of these issues hamper and impact our daily operations. We take it for granted, but we cannot. To that end, we will show you ways on which IGIS and partners, in this case, Fifth Column, have developed solutions to better protect the applications and data that is so critical to our success. To that end, we will also be using this event to award and recognize 3 different groups or recipients of 3 different awards that I'll chat with you about for a moment. We have the Robert P. Schumett National Public Safety and Justice Contributor to Excellence Award, named after our first president. We have the first ever Thomas J. O'Reilly Innovation Award for technical innovation that has contributed to the advancement of information sharing. And that was named in honor of a true leader in hometown and homeland security, and a very dear friend to the IGIS community. And our first ever Corrections Information Technology Recognition Award that honors a team achievement for technical innovation in the corrections field. That is something that we'll be doing during our closing session tomorrow. But as I said, we will be sharing with you updates throughout. The other things that I wanted to mention is that maybe the event this morning was fortuitous, because we would love if you all treated this session as a working meeting rather than a one-way dialogue at a symposium. If we were in the same room together, we'd be socializing, we'd be having lunch together, we might have a refreshment after a day like this. And we would urge that you use that to our advantage, and please jump in with questions. Some of you are seeming to defer to the chat room. Don't be shy, and please join us on stage if you have questions for any of our speakers or for any of our staff. So with that in mind, just know that just as our organization is successful based upon the contribution and the partnership that it has with the organization, so is the case with this event. The more you engage, the more you get involved, the more successful this will be for all of us. So I close with the notion of bridging what is our first sponsor. I think we made reference during Dan's conversation that we had 5 sponsors that we're very grateful to. In addition to our sponsors, our staff has done a yeoman's job. But our first video that we want to share from our sponsor is from Global Flight Group. And I will tell you that Global Flight represents many different things. But most assuredly, a dedicated member of the IGIS community. It represents what is a board member, Roger Mann. It represents active and fully engaged participation on our Emergency Communications Response Committee and Advisory Board. And there are few amongst our members that stand with the dedication to serve the public sector. So with that in mind, I will recruit Alex to present our first video of the 2-day event, and I will remind you that we regroup on a different bridge for the next session at 11:30. So if you could come in a couple of minutes early, we would appreciate it, and we will then be introducing you to the first town hall team. So thank you very much, and we'll see you shortly.